moment, but I do want to go ahead and just start right now and say, hey, my name is Derrick Varner. I'm one of the clinical educators with Thermo Fisher Scientific and working in the immunodiagnostic division. And just a little background about me, I'm a retired Air Force with over 30 years, nearly 30 years serving, and I reside in San Antonio, Texas, where I decided to stay and not shovel any snow. And so I just want to welcome our guest, Dr. Hall. Could you share who you are, where you reside at this time?
Yeah, happy to. So I'm Dr. Geoffrey Hall. I currently reside in Durham, North Carolina, where I'm completing my research year and fellowship. I am board certified in both pediatrics and allergy and immunology. And as I said already, I'm really excited to talk more today.
Awesome. Well, sir, I would just tell you, well, this month is May, and two important things happen in May. I would tell you that my birth month is May, my birthday. I just celebrated another year. Super excited about that 2 days ago. And also, May is what we call it's National Asthma and Allergy Awareness Month. And so it's been set aside that we can set time aside so we can bring about an awareness and educate people about asthma, and also spend some time because it is one of those life-threatening conditions that don't get a lot of attention. And also we're going to talk about the importance of the asthma care, okay? So we would like to begin with just the question, Dr. Hall. What is asthma?
Sure. Yeah. Well, before I answer that, Derek, I want to say happy birthday.
Yeah, thank
That's
you.
super exciting. Some good times to have birthday in May. You got Memorial Weekend coming up, so hopefully everybody's going to have some fun plans for that.
Yeah.
But yeah, to get to the question, so I guess in simplest terms, asthma is really this chronic form of inflammation in the lungs that makes it really hard to breathe. And there are a couple different types of inflammation that can happen in the lungs. So asthma really specifically focuses on this inflammation that causes constriction or narrowing of the airways, where they get smaller, make it hard to breathe out or exhale. And a lot of times we'll use the term obstructive pathology or obstructive disease to describe asthma. So.
Good. Thank you so much.
Yeah.
Also, I heard this term, and if you can help the listening audience out, what is this term called, the atopic march or the allergy march? And could you comment about that, and how does asthma play into that concept?
Sure. Yeah. So we get this a lot in practice because you read about it a lot. So the allergic march or atopic march, they're slightly different. The words atopic and allergy, and we won't get into the weeds too much in the differences there because they're kind of synonymous when we talk about it in the context of this. But we really think about it as a phenomenon or kind of natural progression for patients where they'll start with one allergic condition and then over time go on to develop additional allergic conditions. So traditionally, by the textbook, we're really thinking about it starting with eczema in infancy, and then it goes on to food allergies, and then it goes on to those environmental allergies, or sometimes called seasonal allergies, which is those runny nose, congestion, itchy eyes. And then the final step of that tends to be asthma. Now, even though we call it a march and we always think about it, or it's taught as eczema moving forward, it doesn't always happen that way. So you can start with another allergic condition first, and then it can progress. But we know your risk is higher as you develop these allergic conditions for additional ones. Likewise, and to make everybody hopefully a little more comfortable, every patient, every baby that has eczema is not necessarily going on to develop food allergies or asthma. So we know the risk is there and there's the potential of it happening, but it's not a guaranteed process. So we just kind of highlight it and keep track of it. And when we're thinking about a child's risk potentially of developing asthma in the future, we want to make sure we're aware of other atopic or allergic conditions that are there because it does predispose them to risk. And a lot of times you'll see some of those questions come up as a patient if a physician is trying to figure out your child's chance of developing asthma in the future.
Got it. So thank you so much. That's very helpful. Here's another question. This is like a two-part question. So what are some of the common symptoms that a patient with asthma may have? And what is the prevalence of asthma within the United States?
Yeah, so I guess the most common or recognized symptom that people probably think about with asthma is the wheeze, right? So wheezing is really a symptom we can see in other things that are not just asthma, but it tends to be the one that most people hear asthma and they're like, okay, this is somebody that has wheezing. Other things you might see with asthma: shortness of breath or dyspnea that we use in the medical lingo, a dry cough, chest tightness. Now, if these become really bad or severe enough, it could be difficult for somebody to actually get oxygen into their body, and that can end up resulting in more significant or severe symptoms like rapid breathing, dizziness, drowsiness, or even possibly death. And that's why we highlight asthma as a really important topic to talk about, as you guys are doing today, as we're doing today, because patients still do die from asthma. In the US, the prevalence is around 6.5% in kids, 8% in adults when you look at the CDC data. There are other reports out there that imply the prevalence could be higher, up to 11 or 12%. And that's probably just because of reporting and recognition sometimes. But about half of patients that have asthma actually have a form of asthma called allergic asthma, right? And that's the asthma that's triggered by allergens or allergies. And those are things like trees and weed pollens and dust mites.
Okay, good, good. Now you hit on something, triggers. What is a trigger, right? And how do they contribute to the patient having those symptoms, especially those asthmatic patients that have those triggers? Help us in the audience understand that a little bit more.
Yeah, so I mean, trigger is kind of the giveaway word here, right? So it triggers inflammation in the lungs and the airways that kind of leads to worsening of the underlying symptoms that a patient may be having. And it can lead to two problems. So getting exposed to triggers can, in the short term, cause that kind of acute narrowing of an airway, leading to an asthma exacerbation, which makes it increasingly more difficult to breathe. And these often require patients to take some sort of rescue therapy. I think the one that we most often think about or is most well known is like an inhaler, like an albuterol inhaler. Other times when it's more severe and more significant, some patients will end up needing to seek some sort of medical attention, whether that's an emergent medical evaluation or with their primary medical provider. It just kind of really depends on the severity of the symptoms. In the long term, those triggers also contribute to chronic inflammation. And this is really where we want to get to when we talk about control of asthma and managing asthma for patients, because that chronic inflammation can ultimately cause kind of irreversible injury to the lung and make breathing in the long term more difficult and not something that we can correct. So like I said, as providers, we really want to talk to our patients, or we really often talk to our patients, not only about managing those acute episodes and preventing kind of life-threatening emergencies, but also gaining really good control over the day-to-day symptoms that they're having. The second part of that question, I think, was what are these triggers? So what are we talking about? Yeah,
Right, exactly.
so perfect. Well, we kind of split them up into allergic versus non-allergic triggers when we're thinking about it, particularly in this month. So the non-allergic triggers, those tend to be things that cause not so much allergy, of course, but irritation to the airway. So some of the examples we'll give for those are things like cigarette smoke, secondhand smoke in particular, air pollution, things like strong fumes, like perfumes or chemical fumes, respiratory infections like the common cold can cause inflammation, irritation, and trigger exacerbations. And then some patients, even strenuous exercise can end up inducing some of this inflammation. On the flip side, for the allergy triggers, these are the things that we're commonly thinking about in the spring, the summer, and the fall, most commonly for the seasonal stuff. And those happen to be in the spring, our tree pollens. Here in North Carolina, we get a wonderful yellow dusting that comes out early in the spring. And I say wonderful very sarcastically because nobody enjoys it. It creates a complete mess. And I also have allergies, so I'm miserable during that time. And then in the spring, the summer, we start thinking more about our grass pollens, and then the fall, our tree pollens. And then you may also hear about some molds as well, and those tend to be seasonal. When we're talking about molds, we tend to be talking more about outdoor exposed molds, and those can pop up usually in midsummer and continue into the fall. So those are our seasonal allergen triggers. For our perennial allergies or our all year round allergies, we often think about these as like the indoor things. Dust mites tends to be really high up there. Cleaning your house, get dust mite coming up. A lot of people get the sneezes and congestion. But you also get pet dander, cat and dog, because they're obviously very domesticated in many homes.
Mm-hmm.
And then some other things can pop up like cockroach and even mice. Those two tend to be a lot more relevant, particularly with asthma for patients that are in more urbanized areas, just because the population's higher there and you get more of that infestation issue. But it's not uncommon or not unusual that sometimes you may see it somewhere else. And so with asthma, being able to narrow down what triggers tend to cause symptoms for patient is helpful in both prevention and in treatment. And it's not always a straightforward process. So.
Right. Right. So thank you for sharing that. Now, because it's not straightforward, right, and we know that it was estimated about 26 million plus patients are plagued with this chronic inflammatory disease state that you talked about, right? And, identifying those triggers can be challenging. But we want to ask you, inquiring minds want to know, how can a clinician improve their accuracy and actually minimizing the guessing that we tend to do? So how do you as an allergist and as me as a primary care clinician go about identifying those allergen triggers? And what test methods can one use to help patients out?
Yeah, so I mean, the first part isn't, I think, necessarily unique just to us as allergists, and that's history, and some more history. What patients can tell us about what's going on in their day-to-day lives, their symptoms, really can help us narrow down and focus in on some of the things that we recognize as triggers, and then identify ways to kind of intervene and even prevent exposure to those. So we'll ask a lot of questions about the symptoms they're experiencing, whether that's, runny nose, itchy eyes, cough. We'll talk about things surrounding activity or physical activity. As I already mentioned, exercise, of course, can be an inducing factor for people with asthma. Exposures to any types of triggers that might have happened or patients may have recognized happen during particularly acute asthma exacerbations, or anything that may just make their breathing feel worse. Unfortunately, for the non-allergic triggers, those things that cause the irritation to the lungs, there's not a whole lot of specific testing that we can necessarily do that's going to pinpoint it. So history is really important here. And a lot of times avoidance ends up being the primary objective to prevent exposure or to prevent those exacerbations from happening. However, the allergic triggers, we do have some options available, and those kind of come in two types of allergy testing. And a lot of people are probably familiar, if they've heard of allergy testing, they're really thinking about that typical skin prick test. If you've seen photos of it before, you see some pictures of people's arms or their backs, and they've got some hives that are going on there after their allergy test. And that's really what it involves. It's small little, I'm going to say pricks, even though I've had this done myself. I don't think it feels like a prick or like a needle stick. It's definitely not that uncomfortable in terms of the process of doing the testing. And then it sits, as part of that test, what you're getting is a prick of the allergen we think you may be likely to react to. And there can be quite a few depending on the panel and the symptoms for the patient. Those stay on the skin for about 15 minutes, and then we kind of come back in and take a look. And this tends to be the part that's most uncomfortable because there's certain parts that can be really, really itchy for patients. But the good news is after the 15 minutes is up, we take some measurements and can give some anti-itch cream, and they resolve relatively quickly within an hour or so, generally for most people, and you're on your way. The second type of testing we have is a blood test, and that blood test focuses on an antibody called IgE, and this is the quote-unquote allergy antibody that we're looking at, and it's specific IgE to specific allergens. So we're able to isolate and look at, again, which type of trigger may be most likely for you in whatever clinical context you're coming in to see us for. And we do pretty frequently get the question, which test is better? Which one should I do? And it's not a straightforward and simple answer as one's better than the other. It's really, again, in the context of each patient. Each test has certain benefits and limitations. So for example, if you're coming in and your allergies are terrible and it's in the spring or the summer and you're like, I need my allergy medication day in, day out, something like loratadine or cetirizine, well, skin testing may not be an option for you because unfortunately, well, I should say, fortunately, those medications tend to work well for some patients, but unfortunately, it also prevents or restricts our ability to do the skin testing. So in that case, maybe the blood test is the way to go. You could also stop your antihistamine, which you may hear allergists recommend before a visit. And the primary reason for that is so they can perform that testing effectively. But that's not always an option for every patient. On the flip side is the blood testing. I guess the bigger downside of the blood testing in and of itself is that there's a time delay between the test itself and the results you're going to get. So when you come into a visit, if you're trying to get your answer really quickly and come up with a quick plan the day of your visit, well, skin testing gives you that option, where blood testing is going to take a certain amount of time. Somewhere it ranges for labs, but 24 to 72 hours generally before you'll get those results back. So it really just kind of depends on the conversation between you and your allergist.
Okay, gotcha. Thank you so much. I know that's very helpful.
Yeah.
Let me ask you this. In regards to patients, how are patients triaged to you or seen by you as an allergist or an immunologist to be evaluated for asthma or to figure out those triggers?
Yeah. Yeah. So I guess, again, probably two primary ways that it ends up happening. The first would be referral from whomever the patient's seeing as their primary medical provider. So it could be, primary care physician. It could also be, say, a patient that has asthma that's followed by a pulmonologist or a lung doctor. And as part of their care, they may ultimately end up going forward with saying, hey, we really need to figure out if we've got some triggers here for your asthma that are happening. So let's get you over to an allergist. So that would be the first. The second is kind of a patient-driven and self-decision to come see an allergist. They realize they got all these symptoms going on and they want to figure out what's going on. And that can happen. It just kind of depends on every single clinic may have a different process. Every provider may have a different process. And then some insurance providers also have certain restrictions in place. So you may require a referral from your insurance company before you're later available to see a specialist like an allergist. So it just depends, but there are options.
Good. It's always good to have options. Now, once they decide on the option and they need to get in to see you, what can a patient or the parent, right, if they're a child or a pediatric patient, what can they expect to see when they come to you? What can they expect?
Yeah, sure. So I hope a really friendly and helpful experience. That's our goal, right? We really want to make this as positive of an experience for you to get you on the path to feeling better. So like most medical visits, you're going to get, questions about what really brings you in to see us. Even though I know you share that information when you call in to schedule, we're going to ask it again because we really want to hear direct from you what's going on and what's the most concerning thing that you're finding and what's bringing you to see us. We'll talk a bit about medical history as we do with every other visit, your family's medical history. We'll talk about medications and then get down to some really specific questions about the problems that you're coming in with to see us. Right, so asthma, this could be things like what types of medications you're using currently to manage your asthma, including the dose. We'll get really specific about the inhalers. We may even ask you to bring those inhalers in so we can look at them. It's usually an easy way, so you don't have to remember all of these things. We'll ask maybe how often you're having exacerbations, any known triggers that you've identified or things that you recognize as being problems for you. Talk about any severe symptoms or severe episodes you've had, particularly those that lead to hospitalization, or for some patients when they require a breathing tube to help them when it's really bad. We'll talk about allergy symptoms, of course, and then any other medical tests or evaluations that you've had done. And we might recommend at that point, once we've had those conversations about next steps, which could be things like skin testing, as I mentioned, maybe the blood testing or other blood work, possibly talk about breathing tests. For those that have had them before, obviously they're familiar with them, but that's usually either in a chamber, if it's a really, really formalized type of test, or into a tube, into a piece of equipment. And that's helping us really measure how your air is moving in and out of your lungs. And then we'll work together to come up with a plan to move forward. Again, depending on how much information we have at the time, that plan may evolve over the coming days once the visit's over. But we'll really hope to talk about what we can expect going forward.
Got it. So you mentioned a plan, right? And it's important. I assume once the correct diagnosis is made, right? You got the history, you got the symptoms, you do your exam, you do the appropriate diagnostic testing that you have at your disposal, and you can come up with a very personalized, customized plan for those patients, especially for those pediatric patients or those children who are going back to school or going back to college, or even adults, right? Talk to us about a plan. What plan is available out there that you as a specialist or me as a primary care provider can give to our patients to educate them during those seasons or all year round? What does that look like?
Yeah. So for asthma, that's kind of founded in what's called the Asthma Action Plan. Again, something people with asthma, I hope are very familiar with. So this is a really well-established kind of framework for how to manage your asthma. And there's 3 steps for it. And there's a lot of different varieties of this plan out there, but they all kind of have the same 3 sections, which is green, yellow, and red. A color scheme we're all pretty familiar with, right? So the green section is kind of your good, everyday, normal, routine care in asthma. And this may include your controller inhaler, which is often a phrase that's used, or your maintenance inhaler, or even an oral medication as well. And this is the thing you're going to be taking all the time, right? Just every day up, taking it, maybe going to bed, taking it as well. The yellow section is for I'm starting to feel bad. Something's not right. I'm going into maybe my breathing's getting a little harder. I'm starting to feel that chest tightness. So this is kind of that middle ground, and when we'll often recommend use of a rescue type medication. Again, tends to be that albuterol inhaler, which we hear about a lot. The next step is the red section, and this is the section that says, hold up, things are not getting better, things are going downhill. And often we'll recommend higher doses of that inhaler that we were using for rescue, or even you may have, if your asthma is really bad, an oral medication on hand like steroid. And when that occurs, we will often then also suggest going to see either an urgent or an emergent evaluation for physician, because clearly what you have at your disposal is not taking care of the symptoms that you're showing.
Gotcha. Yeah. Thank you.
Yeah, of course.
All right. And as we wrap things up, can you comment to our patients, how should they be prepared when they come to you with questions as the specialist or me as a provider? What can you share with this audience to prepare for that?
Sure. I guess it would be, I like my 2s here. So 2 things, right? So the first would be to help us help you. And it's kind of giving you some homework to do as the patient, but it's so incredibly important to make the progress of your care move efficiently. We want to get you better as fast as we can. So when I say help us help you, I mean, do your best to come with information to your physician with a goal in mind, right? Make sure you've got your symptoms well categorized out. Make sure you got your medication set. And if you have any additional or prior results from other testing, please bring it along with us, because we want to be able to take that information, kind of form a picture of who you are as a patient and who you are and what experiences you've had already, and then start moving forward, rather than putting you through the process of going through all of this stuff again, doing all this tests again, doing these unnecessary steps that you've already had done, and then get a really clear picture of your disease and move forward. And the second is, don't be afraid to speak up. When it comes to care, like, we are all part of your team. That is our goal. We are here for you, right? You're coming in to see us. We want to figure out how we can best help you move on. And you know you better than anybody else, right? We can't tell you who you are or what you're feeling, but we can try to help work through those symptoms in that process to kind of advance your care, and not only help you get better, but feel better. And quality in life for us is also really important in our patients. So
That's good. Thank you, Doc. And that's so important. You mentioned something, as we all know, something called shared decision making. Like I said, it's a partnership with you, the patient, and the parent, right, to come up together with that plan, right, and how you want to manage those. And so thank you so much. And hopefully we can keep people out of the urgent care and emergency rooms, right?
I hope so.
With this increased awareness and how to go about identifying those triggers and the different tests that are available. So we thank you for that. And as we let me just check the chat right now, see if there's any questions from the group for you or myself. And let me just get a second here. And then I'm looking, I don't see any questions in the chat. And with that being said, I just want to say, do you have any, let me look one last time. I'm a little slow on the draw. There's no questions. So with that being said, as we close, are there any last tip or tips you would like to share with the audience today before we close out?
I guess I would just say and really encourage anybody who's struggling with their asthma or allergies to really reach out, like find the support, find the help that you need, whether that's through your primary medical provider, whether you come see us as allergists or pulmonologists, whatever it may be, reach out and do what you need to do to get yourself feeling better, because we're here to help you. So
outstanding. Thank you so much. Well, everyone, as we close up, we just want to say thank you for joining us today on this Allergy Insider. And we just want you not to forget to please tune in to the next Ask the Insider in June. So until next time, myself and Dr. Hall just want to say take care, have a good weekend, and see you next time. Bye-bye.
bye.